Lymphocytosis and anemia. Case. Dear Doctor. Re. Mr. John Leeds, aged 70 years. This retired bank manager reports a 7-month history of feeling tired all the time. His hemoglobin, HB, is 8.8 g/dl, normal range 11.516, mean corpuscular volume, MCV, 91 FL, normal range 8100, platelets 196 × 10^9/L, normal range 150/400, white cell count, WCC, 83.6 × 10^9/L, normal range 411, with neutrophils 3.2 × 10^9/L, normal range 27, and lymphocytes 79.4 × 10^9/L, normal range 13. His blood film shows lymphocytosis and smear cells. I am worried about these abnormalities. Please investigate. Yours sincerely. Introduction. There are two main goals. First is to establish the diagnoses for the anemia and lymphocytosis, remembering that anemia may be multifactorial in its etiology, for example chronic lymphatic leukemia, CLL, with marrow failure plus autoimmune hemolysis. Second is to assess the effect of the anemia on the patient's quality of life, which will affect treatment decisions with respect to both the anemia and its underlying cause. Asymptomatic patients with CLL who have mild anemia, but otherwise preserved counts, no problems with adenopathy and no constitutional symptoms may initially be best served by a watch-and-wait policy rather than chemotherapy. Except in the most urgent cases, where the patient is clearly compromised by the degree of anemia, e.g. heart failure or angina, time should be taken to find the cause of anemia before arranging a blood transfusion. This is because transfusion is not necessarily required in some cases, e.g. hemolytic anemia or hematinic deficiency, and may not help the situation. If transfusion is clinically indicated, ensure that appropriate tests are taken before the transfusion is started, e.g. vitamin B12 or folate, to obtain reliable results. The possible causes of lymphocytosis are given in Table 4. History of the presenting problem. Is the patient suffering from the anemia? The letter of referral says that the patient is tired all the time, but establish his exercise capacity and ask the following questions in particular. Do you have chest pain? This would indicate myocardial ischemia. Are you short of breath at rest, or waking up at night with breathlessness? This would suggest possible heart failure. Try to determine the cause of the abnormal blood results. Ask the patient the following questions. Have you noticed any lumps? Suggests lymphadenopathy. Do you have abdominal pain? Indicates hepatosplenomegaly. Have you become yellow or jaundiced? This could mean a viral cause, the hemolysis. Have you traveled recently and, if so, precisely where and when? Infections may have been contracted from these locations. Do you sweat at night or have fevers? Have you lost any weight? These are B symptoms associated with hematological malignancy, or could possibly be due to an infection. Have you had any joint pains, swelling or rashes? These are exceedingly unlikely in a 70-year-old man with a raised lymphocyte count, but particularly in a young woman with hemolytic anemia. Always consider systemic lupus erythematosus. Are you more prone to infections than usual? Do you bruise or bleed easily? These are signs of bone marrow failure. What medications are you taking? Check each drug the patient mentions in the British National Formulary Product Data Sheet to see if it can cause hemolytic anemia, which is induced, via a variety of different mechanisms, by several drugs on rare occasions, e.g. methyldopa, penicillins, cephalosporins, quinine, and sulfonylureas. What is your lifestyle? Make sure you exclude high-risk behavior, even in a 70-year-old. NB. In taking a systematic hematological history, ask about symptoms that might be due to problems with red cells, anemia, white cells, infection, platelets, bleeding, lymph nodes, swollen glands, spleen, left upper quadrant pain or discomfort, constitutional symptoms, weight loss and fever. Other relevant history. A comprehensive past medical history is required as a patient's threshold for developing symptoms at a given level of HB varies depending on their underlying general medical condition. Otherwise, healthy patients will often tolerate their HB falling to 8G/DL before becoming symptomatic. Patients with a history of ischemic heart disease or other chronic illness will frequently develop symptoms as their HB drops below 10G/DL. Plan for investigation and management. FBC, reticulocyte count, and peripheral blood film. The patient's MCV, normal in this case, and reticulocyte count may be significantly raised due to hemolysis. Note the platelet count. The peripheral blood film may suggest the diagnosis immediately, e.g. blasts in all, mature lymphocytes and CLL, clearly the most likely diagnosis in this case, or atypical lymphocytes in viral infections, Fig. 4. Likewise, spherocytes and polychromasia will aid a diagnosis of hemolysis. In routine clinical practice, speak to your hematologist about these tests and arrange to go along and have a look. Other blood tests. To establish the presence of hemolysis, check liver function tests, including bilirubin, conjugated and unconjugated, since the latter will be elevated in hemolysis, lactate dehydrogenase, elevated in hemolysis, and serum haptoglobin, low in hemolysis. To look for the cause of hemolysis, check the direct antiglobulin test, also the Coombs test. These will be positive in autoimmune hemolytic anemia, and, as clinically appropriate, the Paul Banel and monospot will be positive in infectious mononucleosis, viral serology, and autoimmune rheumatic serology, for antinuclear antibodies and complement levels. Also check vitamin B12 and folate, these may become deficient in chronic hemolysis, as well as ferritin and serum immunoglobulins, these may be suppressed in CLL and can be responsible for recurrent infections. CXR and ECG. Look for hilar lymphadenopathy. Is there evidence of heart failure, ischemia, or strain? Management. This depends on the symptoms that the patient is suffering. Clearly, if he is experiencing unstable angina as a result of the anemia, then admission for transfusion will be appropriate. However, in routine practice, most patients are not acutely unwell and their symptoms are chronic but not life-threatening. Outpatient follow-up in 4 weeks will give sufficient time for all the results to come back and a diagnosis be made. Patients should be told to contact their GP or the hospital should they become more unwell in the interim. NB. Patients should receive blood transfusions only if their anemia is symptomatic, not because their HB has fallen below a particular level. Further discussion. Anemia is common and much can be resolved before a patient gets to a specialist hematology clinic. However, serious anxieties often arise before the outpatient appointment if a patient is told that a raised WCC may be leukemia. Such anxieties are often unnecessary and the L word is probably best avoided until a hematologist has made an assessment.